progression, and second, to introduce the repigmentation, and third, to prevent the relapse. So various therapeutic options in childhood vitiligo are topical therapy like corticosteroids, calcipotriol, tacrolimus, and combination of all these. Various systemic options are corticosteroids, either daily or oral mini pulse therapy. I shall be talking about each one of them for a couple of minutes. Phototherapy is systemic solar and ultraviolet light therapy, what we call as PUVA therapy. Then various surgical options like narrowband ultraviolet B1 therapy, excimer lasers, mini punch grafting, suction blister, and last but not the least is cognitive therapy. Before that, camouflage also comes. But cognitive therapy, as I told you at the very beginnings, reassurance, counseling is extremely important. In this case, since we are talking about the vitiligo in children, it is the counseling of the parents which is most important. Now, let us talk a bit about the non-segmental vitiligo, which is less than 10% of body surface area when it involves. There are few options like topical potent steroids, topical tacrolimus. Various vitamin D3 analogs have been used for quite some time, and combination of all this. The topical calcineurin inhibitor has replaced topical steroid for long-term maintenance of therapy because of several advantages, like it does not produce atrophy of the skin, perilesional hypopigmentation, telangiectasia, and there is no chance of absorption of the topical steroid-like thing and going into the systemic circulation. The very simple reason is topical tacrolimus is a macromolecule, is a big molecule. It does not get absorbed through the skin that well. Now, the treatment outcome of the disease, depending on that, the first line of therapy is topical steroid though, but for long-term maintenance, it is the topical tacrolimus. For widespread vitiligo, when it is more than 10% of the body surface area affected, various treatment options are phototherapy, either in the form of the conventional, which is going on for decades together, solar and ultraviolet A therapy, or more recent narrowband UVB1 therapy. Combination of narrowband and tacrolimus has also shown good results. For rapidly spreading vitiligo, we give various immunosuppressions like cyclosporine, methotrexate, azathioprine, and of course systemic corticosteroids, as I mentioned at the very beginning, either daily oral therapy or a mini pulse, means you give a short course of oral corticosteroid on 2 consecutive days a week or once a week, like that. Narrowband ultraviolet B1 treatment has revolutionized the therapy of vitiligo. It is said that this smallest child, the treatment option is for vitiligo in a very small child is definitely narrowband UVB1 therapy, and there is no adverse effect practically. And it itself can prevent the progression of the disease. That is narrowband UVB1. Progression of the disease, as well as it causes repigmentation by stimulating the melanocytes. Now, coming to next, latest option is excimer laser. It is targeted phototherapy. It repigments for 50 to 75% of cases. There are patches actually seen in practice which doesn't respond to any kind of therapy, where excimer laser is of immense importance. And it has been seen to be showing good results, when it is combined with topical pimacrolimus. And it is most beneficial for segmental vitiligo, because segmental vitiligo, nothing works actually. Of course, recently introduced, tofacitinib, I shall be talking about that, has shown promising result when combined with narrowband UV-1. But by and large, for resistant therapy, therapy-resistant patches of vitiligo, excimer laser is very useful. Methylprednisolone pulse therapy has shown promising result, but it is debated whether pulse therapy result is many long-term follow-up post methylprednisolone pulse therapy has shown a significant percentage of patients having relapse. Various immunosuppressants which have been used for preventing the progression of vitiligo, for rapidly spreading vitiligo. One is cyclosporine. I myself personally use a lot of cyclosporine. Pulse therapy, well, I used to use when, 3 decades ago when I was in PGI Chandigarh as a resident or as a junior resident, as a senior resident also. But subsequently, we found that there are cases which with whom we have got very good result and have seen the complete remission of the disease. Many of them started coming back with relapse. So since then, I have stopped giving methylprednisolone pulse therapy. Nowadays, I am not a strong proponent at all for methylprednisolone pulse therapy. Rather, I prefer cyclosporine to halt the progression of the disease. There are various regimens mentioned for the treatment with cyclosporine. Dosage can be variable, though it is mentioned here in this slide as 3 milligram per kg per day. But there are, children in whom I have given up to 5 milligram per kg per day. Its progression is halted in a good percentage of patients. And with the progression, halt, we see repigmentation also. It is well tolerated. There are very minor side effects, if at all. Mostly, some of the children complains little bit of burning sensation in the stomach. That is the only side effect. Now, another option is methotrexate. And particularly, for our country where cyclosporine is costly molecule, this particular molecule is very useful in the sense that it is cost effective also. And low-dose methotrexate has been seen to halt the progression of the disease. Pulse therapy with oral betamethasone has also been found to be effective. Oral betamethasone plus azathioprine also some people have found it is to be good. Now coming to various surgical modalities. What are the surgical modalities? Surgical modalities basically grafting, as I mentioned, either split thickness skin grafting or punch grafting. Most popular is the punch grafting. Various emerging therapies are, low prostaglandin, antioxidants, and various other molecules which are in the pipeline. Now, let us talk about some newer development in the treatment of vitiligo, which has recently created lot of buzz as far as the treatment is concerned, like topical application of two molecules. They are JAK inhibitors, as it is called. One is tofacitinib and the other one is ruxolitinib. So both of them have been found to be extremely useful for treatment of vitiligo. Ruxolitinib is not as yet available in India. It is available in grey market, but not been available as such. But I'm sure that it is going to be available soon. That is the kind of indication I have got from the market. And tofacitinib is a very cheap molecule in India. Although internationally it is a costly molecule, we have got this luxury of using it actually at a very low. And topical tofacitinib, oral tofacitinib I have been using a lot for treatment of vitiligo and getting excellent results. This is ruxolitinib, topical JAK inhibitors, US FDA approved. Though tofacitinib is not US FDA approved indication for vitiligo, but we have been getting by its off-label use very good result. As you can see here, some of the results is ruxolitinib. There are many literatures published on it. Topical tofacitinib has also been, documented well, along with ultraviolet B1 therapy. My personal experience, if you ask, is excellent combination is not only topical, oral tofacitinib also, I give a lot. Many of our colleagues also give, along with topical, along with narrowband UV B1 therapy for repigmentation. And we have seen that when we give oral tofacitinib alone, the kind of result we get, it is multiplied when we combine narrowband UV B1 along with that. Various biologics for treatment of vitiligo. One is rituximab, TNF-alpha inhibitor, infliximab, adalimumab, and etanercept. They are mostly, in literature, and as far as the discussion, as for the sake of academic discussion, not much used by and large. And there is not much approved data also. It is very important to have general skin care for vitiligo patient. You have to ask the parents not to scratch the skin, not to vigorously rub, because there is a chances of covernalization on the skin and the vitiligo can spread on the line. Not to allow them to wear any rings or amulets or charms. All these things can catching on the skin. Skin has to be moisturized. That is very important, so that the roughness of the skin is taken care of. And any kind of treatment on a smooth, moisturized, pliable skin shows good result by and large. And the child has to wear a full sleeve cloth, because when the treatment is on, there is some pigmentation. Melanocytes cannot be just stimulated on patches. Generalized melanocyte stimulation occurs. To prevent the tanning, you have to follow this policy of using full sleeve clothes. Avoid trauma, I mentioned. Regular use of moisturizers and sunscreen mentioned. Cosmetic camouflage is for limited patches. Those who prefer, I always ask the parents or the adult patients whether they will opt for cosmetic camouflage, particularly while attending some social events, to avoid the stigma associated with this disease. It is very important to give them cognitive behavioral therapy, because vitiligo is a disease which is still a social stigma, and children suffer from social ostracism very badly because of vitiligo patches. And there are support groups created all over the world, including in India also, for vitiligo children. Now come to the natural course of the disease. Rate of spontaneous repigmentation is more common in children. That is one plus point as far as the childhood vitiligo is concerned. Segmental vitiligo, once repigmented, it's not relapse, unlike in adult. Then periauricular vitiligo repigments spontaneously. Many children we see it is spontaneously. Pigmentation can occur after sun exposure, so that's important. Cosmetic camouflage, as I mentioned, is very, very important. Now, in the last part is the role of counseling. The role of counseling and psychotherapy cannot be overemphasized. It has got a tremendous role, because the children suffering from vitiligo, they suffer from self-esteem, they have lack of confidence. Not only their parents also have got the similar kind of features. So a lot of counseling one has to do for the parents as well as for the child. So to conclude, there are therapeutic hurdles in vitiligo, but it can be completely cured for in the right direction. Long-term efficacy of the treatment, safety and sustained effects needs to be explored for each molecule. Medical therapy is the first line of treatment in pediatric vitiligo. Narrowband therapy is extremely useful and helpful, as I mentioned from the very beginning, and can be used as a maintenance therapy. Before I finally conclude, that I must say this, particular message, convey this particular message, that please tell your patients of vitiligo on the very first hand that vitiligo, if treated properly, it can be completely removed, either by medical therapy or whatever is left out by surgical therapy. So try to give them a very positive outlook of the about the disease treatment and progress. Never give any negative outlook by saying, oh, this is the disease which cannot be cured. I'm very sorry that this gives a very bad message and a very negative output to the parents who are already devastated after coming to a doctor. If they get the same kind of response what they have read from the Google or from other internet or from social media, if they get the same kind of feedback, it is very frustrating for them. Practically, yes, vitiligo can be very nicely controlled and cured. That message you are giving. You are not, giving any rosy picture about the treatment. So that you have to maintain and you have to be bold about that. Before concluding, I would like to share our book. Avilas was mentioning about the book. This is the book, Color Atlas and Synopsis of Pediatric Dermatology. In the current edition is the 5th edition, which is currently available in the market. And this book is considered as the best book in the world in skin of color on pediatric dermatology, because this is the only book which has gone up to the 5th edition. And for this book, during the last World Congress of Pediatric Dermatology, WCPD, Buenos Aires, I was felicitated and I was requested to give a talk on this book for 20 minutes. There is the book global. Thank you very much for your patient hearing.
Thank you, sir. Shall I publish the quiz link now?
Yes, please.
So, dear participants, the quiz link is on now. Please appear in the quiz. I have already uploaded the link in the chat. Please appear in the quiz.
Varun, can you please send the link once more in the chat?
Yes, yes.
Varun, it is also better to publish the link in the screen.
Yes, sir. The quiz is on now. Please participate in the quiz.
There is a raised hand question. If you can type it in the chat group, it will be really easy for us to understand.
You can also scan this QR code to appear in the quiz.
We have just checked the link. The link is working. And yes, there are doctors who have completed the quiz. And there is a question, sir,
Yes.
for you in the chat box that how common is hypopigment lesions seen in newborn and within the first 1 year in any case? This is asked by Dr. Manish Shah.
Hypopigmented lesion in a newborn is very common, but let me tell very clearly here to everybody that hypopigmented lesion in a newborn by and large is not vitiligo than 99% of the cases. In a newborn, the hypopigmented or rather depigmented lesion, if at all we see as a vitiligo, it is either a piebaldism or sometimes very rarely congenital vitiligo. But the commonest cause of hypopigmented lesion in a newborn is something which is known as nevus depigmentosus. Nevus depigmentosus is basically a hypopigmented nevus which looks like vitiligo, and you have to know about it. All the causes of hypopigmentation in children, parents are very much worried and they come to a dermatologist with this particular question. The doctor, this patch is not vitiligo, I believe, and you have to confirm it to them. I can see
So
one more question. Pulse
yes.
steroid therapy is, safety of pulse steroid therapy in children below 12 years. I told you that once, that 3 decades or 4 decades ago, I used to use pulse steroid therapy, used to get good result. Well, as compared to daily steroid, it is much more safer. But with the advent of newer therapies, particularly of current days, its safety profile cannot be compared to therapies, newer molecules, narrowband therapies, excimer laser, tofacitinib. So better to avoid pulse steroid therapy, because main problem of pulse steroid therapy that you get good result, but for some limited number of years. You stop it and you follow up these children, you will see after 3, 4, 5 years, they will come back with, lesions of vitiligo again. Any other
So we have
question?
another question, sir.
Yes. Yes, Mr. Jayanto.
Yes, sir. So what is the lowest stage we can use trimechromas and tacrolimus?
Well, Pimacrolimus, though as per US FDA guidelines, you cannot use both the molecules below 2 years of age. But from practical point of view of experience of me as well as several dermatologists in India and across the globe, we have been using Pimacrolimus even for few months old babies, and tacrolimus also the same, more or less from 2 to 3 months we can use, and initially 0.03%, but after 1 year or so it is better to use 0.1% because that is more effective anytime. And Pimacrolimus you can use it from 2 to 3 months of age, and we have been using it. We have never faced any problem. Yes, chances of reactivation of the disease, I mean, they come with the relapse of the disease.
Sir, oral tofacitinib in the latest TB who has completed the treatment.
Well,
This is also a question from Dr.
right.
Raman.
Okay. A person with the tuberculosis being completing the treatment of latest treatment of, to completing the treatment for tuberculosis, whether you should contemplate giving oral tofacitinib. I understand that is the question, valid question, particularly in Indian scenario, where TB is still quite rampant. Once the treatment is complete, you do the test for chest X-ray, repeat chest X-ray for the patient. If there was a limnotuberculosis, do the activity of the disease, you can do a TB gold ferron test, TB gene, as well as TB PCR. If all these are in favor of non-activity of the tuberculosis, or tuberculosis being completely cured, then you can contemplate giving oral tofacitinib if you feel that this is very much needed for the patient. So, and there is nothing like you cannot give tofacitinib. Can certainly give, but before giving the tofacitinib, you have to exclude the possibility of activity of the disease, and just to see that the disease has been treated with full, efficacy and completely cured.
From same Dr. Raman, any chances of reactivation, sir?
Yes, every time there is a chance of reactivation, even if you don't do anything, in tuberculosis, don't treat with tofacitinib, also there is a chance of reactivation. So nobody can predict that.
So then we have another question, sir. What is the treatment plan for a 15-year-old boy with segmental vitiligo on face who is treated with topical steroid tacrolimus, achieved repigmentation and getting topicals?
This is not uncommon, because that is the reason why topical steroid and tacrolimus, they have fallen short of their achieving goal for treating a condition particularly like segmental vitiligo, which is so treatment resistant by and large. That is something which we conventionally have been knowing, and that's why for topical segmental vitiligo in a child, the preferred treatment option is oral tofacitinib or topical tofacitinib plus narrowband UVB1, or even more effective is excimer laser. And if these measures fail, then grafting is the only other option.
So there is one more question. Sir, you have mentioned that tofacitinib and cyclosporin is progressive in vitiligo. Which is better? And could you please mention how to taper the doses?
we have to remember that for cyclosporin, we are basically using it for preventing the progression of the disease. Cyclosporin per se does not cause pigmentation of the vitiligo. But people have seen that while preventing the progression of the disease, normally you must have seen the natural course of the disease I mentioned, there is a tendency of repigmentation of vitiligo. So while the the vitiligo progression is being halted by or slowed down by use of cyclosporin, at the same time you see that some of the patches are repigmenting. So we usually do not give it for 3-4 months at a stretch. There is no need actually, because cyclosporin is not a repigmenting agent for vitiligo. One has to be very clear about it. It is a immunosuppressive, and vitiligo is an autoimmune disease. We are cutting down the autoimmune process, and thereby we are halting the progression of the disease. Right? This we should be very clear about it. Now, this is about cyclosporin. Now, tofacitinib. Tofacitinib, which we